So I think switching gears a little bit, another piece of data that I thought was really important was thinking about use of a CDK4/6 inhibitor in the adjuvant setting for patients with hormone receptor positive breast cancers who have lymph node involvement. So this study, monarchE, had looked at giving 2 years of abemaciclib, which is an oral CDK4/6 inhibitor, with the first 2 years when you're getting your hormone therapy after you've had an ER-positive cancer. So you finished your chemotherapy or radiation or whatever you needed, and you're starting your hormone therapy. For the first 2 years, you would get abemaciclib. And they showed that giving you the abemaciclib did reduce risk of recurrence by about a third, which I think is very impressive risk reduction. And these data that were presented at San Antonio were so critical because now in the trial, everyone's completed their 2 years of abemaciclib. They now have 4 years of follow-up. So it shows that even when you stop the drug, you continue to see your benefit relative to not getting it be there, which is interesting. And we see this with endocrine therapy, what we call a carryover effect. So even though the drug is gone, you're still seeing the benefits compared to someone who didn't get that drug, which is really important, again, because we've been unclear about what would happen once that drug was stopped, but you still see benefit, with the curves even separating further, suggesting that that benefit is continuing. So I think really solidifying the fact that abemaciclib should be considered in people who have higher risk node positive, hormone receptor positive disease. And this is true also looking at distant events. It does not at this point improve overall survival, but I wouldn't have expected it to, because when someone recurs from their breast cancer, thankfully they live many years with that metastatic disease. And so you're not going to see survival be impacted for, I think, quite a long time to come. But I think this does suggest that we likely in the future will see survival impact, because if you look at the number of people living with metastatic breast cancer, you see it's about half the number of people if they got abemaciclib compared to the people who just got a hormone pill alone, which to me does suggest really important impact in preventing distant metastatic disease. So again, I do think these data just solidify the fact that we should use abemaciclib in high-risk hormone receptor positive patients, particularly for those first 2 years after starting endocrine treatment. I think oh, sorry, go ahead.
What's the defines high risk?
So good question. The way they defined it in monarchE was that you had to have 4 or more positive lymph nodes, or had to have 1 to 3 positive nodes, and have a tumor that was over 5 centimeters, or have a high-grade cancer. And so that's what we would think of as a classic eligibility for monarchE. There is a more complicated nuance to this, where the FDA did say you, in addition to those factors, had to have a high Ki-67, which is a assay that looks at proliferation in the tumor. I will say I sort of disagree with that, given the way the data looked. And so both ASCO and NCCN also disagreed with that, and just said you had to meet the general clinical pathologic risk as I outlined. And that's the way I